Welcome to the Sound Health Network's webinar series. I'm Indre Viskontas, your host and moderator for today's event. The Sound Health Network is led by co-directors Julene Johnson and Charles Lim, who also composed our introductory music, and music therapist Sherry Robb and I round out the leadership team. Our mission is to promote research and public awareness about the impact of music on health and wellness. The Sound Health Network is a partnership of the National Endowment for the Arts with the University of California, San Francisco, in collaboration with the National Institutes of Health, the John F. Kennedy Center for the Performing Arts, and Renee Fleming. This webinar series features interdisciplinary conversations between researchers and other stakeholders in our community, representing diverse perspectives and addressing obstacles that stand in the way of our mission. This week, we're going to discuss how music can be used in hospitals and other healthcare settings and in general population health. We'll be discussing artist in residence programs designed to bring the skills and artistry of professional musicians to the clinic. If you missed it, we featured a conversation with Sienna Wesley. She's a musician in residence at the University of Florida's Shands Arts and Medicine program in our monthly newsletter. Jill Sonke is the assistant director of the program, and she also leads the Center for Arts and Medicine at the University of Florida. She studied dance at Interlochen, Florida State, in London, Paris, Athens. She's been a principal dancer and soloist with dance companies in New York, as well as a guest performer and choreographer. She holds a Master's of Arts in Human Services from the University of Illinois and is a PhD candidate in Arts and Public Health at Ulster University in Northern Ireland. And she has more than 25 years of experience as a leader in arts and health. Welcome, Jill.
Thank you so much. I'm delighted to be here.
So I'd like to start by asking you to tell us a little bit about how you went from a life as a dancer to becoming interested in using the arts in medicine.
My early life wasn't as a dancer. Actually, I was a bit of a late starter in dance. I didn't start until my junior year of high school, but I was a gymnast, so I was moving, and I was headed toward a career in medicine. I always wanted to do something in healthcare. I started volunteering in hospitals the day I turned 14 years old and could get my candy striper uniform. And so I studied dance I went to Interlochen Arts Academy in my senior year of high school. I went to Florida State University to study dance. And then I went to New York and danced professionally, and came to Gainesville, Florida for what was intended to be a year. And in that time, this arts and medicine program was just starting. And so I had just an incredible moment of realizing that I could be an artist. And that's is the direction that my life had turned into in healthcare. And that was really amazing to me. So I stayed in Gainesville longer than I expected. In 1992, I started working with the Arts and Medicine program. In 1994, I became an artist in residence, a dancer in residence in that program. So my interest in health was always there, but as I got swept away into the arts, I never imagined that I could land as an artist in healthcare. So when that opportunity arose for me, I never turned back. It kept me in Gainesville and at the University of Florida, where I was also at the time teaching on the dance faculty. So that was the natural merger of my two interests.
Awesome. So joining us as well is Dr. Claudius Conrad. He's a world-renowned pioneer in minimally invasive liver, pancreas, biliary surgery and a Steinway artist. He started his musical studies in Munich, Germany. He has 2 PhDs, one in stem cell biology and the other in music philosophy. And while he was training in surgery at Mass General, he served as the director of music in medicine in the Department of Surgery. He's currently the chief of general surgery and surgical oncology and the director of HBP, which I'm sure it's probably the I'm going to get it wrong, so I'm not going to try, surgery at St. Elizabeth Hospital in Boston. And he's actually pursuing studies of the impact of music in the operating room, on healthcare outcomes, and even on astronauts. So Dr. Conrad, welcome.
Thank you so much for having me, and congratulations for putting this seminar together. I'm very honored to be here with you guys today.
So tell us a little bit about how, I mean, clearly you had these two interests that were side by side. What made you decide that you could use music directly in terms of, what it is that you do?
I was intrigued by the fact that music has always been a part of healing since the beginning of cultural history. And it has become a recent phenomenon that it is not a central part of healing anymore. So I was really intrigued by the fact that music has powers that are maybe not understood in scientific ways. And with my background as a pianist, and as a scientist, I thought of merging the two fields and investigate the effects of music on all kinds of members in healthcare: patients, relatives of patients, physicians, nurses, team dynamics. And back when I started, there wasn't really a field of music in medicine, the scientific investigations of music to help teams in their operating room or patients, but now it has become a wonderful field with many, many branches.
So Jill, can you tell us a little bit about this artist in residence program and sort of what after 25 years of doing this, you've learned that other people can maybe avoid the obstacles of initially to make this work?
Goodness. Well, fortunately, as Dr. Conrad mentioned, this field has really evolved. So when I started working as an artist in residence, I was one of the first two artists in residence at Shands, and there were about 4 other programs in the United States that had started in the late 80s and early 90s. So we were finding our way. Of course, music therapists have been working in healthcare for decades and have very clear clinical practices. But as artists who are not prepared with a clinical background or functioning as clinicians in a healthcare setting, we had a lot to learn. So the staff, nursing staff namely, really did a lot of training for us. So a lot of what we've had to learn across these past 3 decades is what it means to be an artist and not a clinician in the healthcare setting. We've learned to collaborate with creative arts therapists, with music therapists, with clinical staff, and how to understand the tremendous value that the arts have, that artists have in the healthcare environment, all the incredibly powerful things like distraction. And I remember when in the early years of working as an artist in residence, the experiences I was having with patients were so profound and so transformative for the patients, as well as for me actually, but clearly transformative for the patients. And when people would describe artists in the hospital and say, "Oh yeah, you provide distraction, that's really nice," I would feel that felt too small, right? But I've come over the years to recognize that that's one of the most powerful things that we do, is provide distraction. When our musicians in residence play for patients and it takes them temporarily away from thinking about their diagnosis or their, what's ahead of them, or even takes them away from focusing on their pain, it can be an incredible gift. We know that emotionally can be really powerful. It can reduce anxiety, and that in turn can have really powerful physiological effects. So the act of providing enjoyment, engagement, distraction, and connection, expression, all of the things that the arts do, is really, really powerful in humanizing the healthcare experience and in helping to support the patient experience.
Yeah, I think that's a really good point. And so I just want to also just highlight that for people who aren't as familiar, there's a big difference between a musician artist coming in and playing in a healthcare setting and a music therapist who has, a totally different set of training and approach. And so here we're really talking about, artists performing and, working as part of the team, but not in the capacity of official, board certified music therapists. Claudius, I wonder if you could tell us a little bit about sort of your experience with that, what building on what Jill is saying, is that I know that you've studied the impacts of listening to music, patients listening to music before they go into surgery. Can you tell us a little bit about that work?
Right. So while there are many things in medicine that have advanced over time in a drastic fashion. If we think about immunotherapy, the technical advances in surgery, I was intrigued by the fact that, interestingly, the understanding of how music helps patients and how this process is mediated in the body, that this is pretty rudimentary and basically not well understood. So the first study we did was a study in critically ill patients that tried to investigate how music relaxation is mediated in the body. And we found, using Mozart sonatas, specially selected, and an environment that is very, very monitored, we found that there is an inverse pathway that is activated, consisting of growth hormones secreted from the brain that acts on cells of inflammation by reducing a chemical that cells of inflammation use to communicate with each other, called interleukin-6. And this was really the first pathway that kind of explained, if anybody listens to music, how this is mediated in the body. And now we know that this pathway is very important in other aspects of inflammation. And we have since used this pathway to induce healing in our patients. So that was the first study where we looked at the effects of music on patients. And current studies that look in the perioperative space look not only at the effects of music prior to surgery, but also during surgery, and maybe most importantly, after surgery.
So that's really intriguing, the during surgery part, because presumably, I mean, patients are do we know whether they're actually hearing? Is this more for the surgical team? What do you think is the mechanism that, might explain why it might have better surgical outcomes during the actual surgery?
Right. So there's pretty convincing data that even under adequate anesthesia, meaning the patient is adequately anesthetized, the surgeon is happy with the depth of anesthesia, the anesthesiologist, everybody is happy, even in this state of anesthesia and state of unconsciousness, auditory information is processed. And the way I use this understanding in my practice is I ask patients to bring their own music to the operating room, and the patient will listen to their personal preference with headphones during the surgery. And just the concept of personal preference, how musical taste is developed, what is impacted on and how strongly it correlates with your primary personality is another very exciting research field. But you mentioned the surgical team, and we recently published a manuscript in Surgery on the impact of music on team dynamics in the operating room, because you have to imagine that the OR is a high stress environment. And typically, when people come together in a high stress environment, like in the military, in the flight industry, in a nuclear power plant, then they are similar people. Their personality and what drives them is similar. But what drives surgeon, the personality of nurses, the personality of anesthesiologists, the personality of trainees, the personality of staff, is vastly different, yet we have to work together in a stressful environment to work towards the best outcome for our patients. So music in this context has been shown to help synchronize patients and synchronize movement and synchronize people to the best possible outcome. If you think about marches or dancing, it helps us to unify. And we found that musical taste strongly correlates with the primary personality. Surgeons prefer typically more activating music because there's an athletic component in what they do, a motor component. And we know from the athletic literature that if a athlete listens to music while working out, the perceived strenuousness of the exercise is less, while the performance tends to be the same as in silence. the perceived strenuousness is less. And anesthesiologists who have to follow auditory encoded information, they prefer so-called reflective music, jazz, and classical music. So to bring this all together, we looked at various musical genres, and we looked at personalities and how what the role of music in the provider's life is. And we found that in that context, classical music is often a good compromise. It is not the best for all people, but it seems to be a 80% solution, the best for the most. And that helps to unify the team and helps to also break down barriers of communication. If the surgeon, the staff surgeon investigates or asks about the musical preference of his team, that breaks down barriers of communication, which is so important in order to avoid errors in the operating room.
Well, you've just explained so much of the drama behind TV soap operas and the EDs, and now I feel like I can really enjoy those shows much more. So
yeah.
Jill, I wondered if this made me think about artists in residence, and sort of, oftentimes artists will come in with a particular sound, or, they're artists, that's what they create, that's what they do. So how do you reconcile what we've just heard about, sort of personal preference, with the benefits of having a live artist in the space?
Yeah, that's a really great question. We've spent the last few years doing some research on the topic. In one of our studies, we've been investigating for the past 5 years the effects of live preferential music, patient-preferred music, in emergency and trauma care. And in the second phase of the study, we determined that we were only sure we actually had preference from 47% of the patients we enrolled in the study. And we had 1,200 patients in that phase of the study. So that was shocking to us, because that was actually what we were studying. The premise was that preference, as Dr. Conrad has said, is critically important to the effects of music. So we took time out and developed another arm of the study to develop what we call a live preferential music protocol, which is kind of a roadmap for how musicians can achieve preference with patients without having to play 20 questions, which can be anxiety provoking when patients are in a healthcare experience. And I've had this experience myself. I've had, gone in for a procedure and they say, what kind of music do you want to listen to? And I'm like, I listen to music every day, but it wasn't a moment where I could choose. So recognizing that we need to be as gentle and efficient as we can in that process, we developed a protocol that allows musicians to figure out how to get to preference, or as close to preference as possible, so that we can study it. So we've been testing that protocol. We've tested it, I think, 15 hospitals across the country, and we're just developing a manuscript for that as well. But it is critically important, and often patients are interested in hearing the musician's preference. Which is great. They want to hear something that the musician has played, or something that the musician has liked. And specifically, in answer to your question, Indre, we recognize that the musicians each come with a particular genre or few genres that they're really strong in, although we hire musicians with the broadest repertoire possible, and our musicians collaborate to build song lists that are lists of songs that are requested commonly, and to learn those songs together so that collectively their repertoires are really, really broad. But we also, a part of that study was investigating how often the musicians choose or play music that aligns with their own personal preferences. And of course, we did find some association there, but even just that part of the study helped the musicians to be aware of that, and to hone the ways in which they go from, a question like, do you want to hear some music today, to something upbeat or something relaxing, or, the ways in which they get to that final song preference, if it's possible.
This reminds me of a company that a friend of mine runs, where the goal is to create, using artificial intelligence and machine learning, a playlist that is specific to a person's physiology. So using a whole bunch of wearables, they sort of track a person's response to music. And then the idea is that the algorithm will suggest music How well, this is a question for either one of you, how well do you think people know what music should be most effective in some of these settings versus how much do you think there is like, just misconceptions and whether there are other ways in which we should approach the question, maybe like an algorithm or using some of these physiological measures?
Yeah, so I think generally all music can be classified in war music or sleep music, lullaby type music. That's how we can categorize all music in the world. And we know that musical preference is determined relatively early, but there are personal factors that contribute to it. It's not just physiology, it's the biography of a person. And yeah, in my PhD, I very closely looked at Mozart's life, and disease and sickness and illness played a tremendous role in Mozart's life, which is extremely well documented due to the fact that he traveled through Europe most of his life and sent letters back to his sister and his mother, who stayed back in Salzburg, to document how he was feeling. So musical preference is determined by some degree physiology, but also experiences. So I think that machine learning, and we have projects on AI in a different field in large data, large outcome statistics, but we know that AI or machine learning may be able to give you an approximation, but probably it is more complex than just the physiology, and the biography of the patient is critical.
I'll share one anecdote. In around 2001, we were doing a study of arts engagement among kids with cancer and sickle cell. So how engagement in the arts affected pain and anxiety among those kids. And we created a lot of original media. This was all looking at the arts delivered via technology. So we created a lot of original media, film, online arts engagement. A lot of music was involved in the media that we created, and we recognized early on that we were bringing a huge bias and assumption, which is that kids who are getting chemotherapy and often dealing with nausea and pain wouldn't want, a lot of hardcore rock music, for example, or really loud, rambunctious, complex music. And we were actually quite wrong. We found that quite a few kids who were actively not feeling well, and nauseous in particular, really did want exactly the opposite of what we presumed. So I think often we do bring those sorts of assumptions. It happens with the visual arts in hospitals as well. There's a big preference toward nature imagery, and it's absolutely the safe way to go. Nature representative, nature art reflecting the regional environment. It's a really safe way to go for art and healthcare. But preference is, across art forms, I think preference is the key.
But also understanding how you want to use the thing. What your story reminded me of when I was in labor with my daughter, and people were like, you should listen to music. And I was like, no, I just want to watch the Lord of the Rings trilogy. I want like an epic story of a winning battle. That's what I want.
Right. If I can interject an anecdote on how preference can also change over time. I was giving a radio interview, I think with WBR or so, and a physician called in and said he, when I was a medical student, was involved in a code where they coded a patient and they had music playing in the operating room, and they coded the patient, and the patient ultimately died. And it was a very dramatic experience for this now physician, back then medical student. And they played Stairway to Heaven in the operating room while the code was going on. And he is so traumatized by this experience. While he loved the song and rock music before, now he is traumatized by it and can't listen to it anymore. So preference is so interesting. It is a reflection of who we are what makes us, and it can change over time. So yeah, I think it's fun because it's so close to you know, us as a person, who we are, because it's a summary expression of our experiences. I find it really, really interesting, and I'm sure you guys have the same experience.
So yeah. Just letting our audience know that if you want to ask questions, feel free to do so in the Q&A, and I'll start bringing some of those up into the conversation in a minute. But Jill, I didn't mean to cut you off.
Not at all. I just, one other little thought around preference. Another thing that we've spent a lot of time thinking about is what preference means. And it actually doesn't mean my favorite song, right? Or my short list of ultimate favorites. We've come to equate it a little bit with a menu in a restaurant. You know, you go out to a restaurant and you get a menu and you choose the thing that looks best. And so often in healthcare settings with musicians and residents, and this harkens back to your question about the performer's own preferences, Indre, you know, they have a repertoire and they offer choice, and patients are happy to choose, you know, within that repertoire, sometimes stretch the musicians, but it doesn't mean that we have to be able to play every possible song and always play the ultimate, you know, perfect favorite song.
So Alan Bruni, who is a rhythm event drum circle facilitator and who often works in healthcare settings, asks if you've looked at the difference between live artists performing versus participatory music making. So I don't know if either of you have looked at that, whether there's a difference. I mean, presumably there would be if the patient is actually participating in making the music in situations in which that is actually possible.
Yeah, so there are a couple of trials, one by our group and collaborators of ours, and a large Canadian trial. The Canadian trial conducted in children, large-scale study, compared listening to music to active music making, being an active musician, and with the outcome in social skills and communication. And the most improvement in social skills were in the group of children that were undergoing piano lessons rather than listening to music or reading or other activities. And then secondarily, we are having a study right now that compares pre-recorded music to what we call live simulated music, where in the context of COVID, unfortunately, a lot of musicians are not able to come, or were not able to come to the hospital and come to the patient room. So we had iPads, but a personalized interaction with the musicians. And we are looking right now, we're analyzing the data, what, you know, how the efficacy of both approaches live music if it compares.
Mm-hmm. Jill, do you want to add anything?
No, similarly, we've done a few comparison studies. We haven't compared live performance to participatory. We've done that with recorded music and found you know, increased benefits around participatory singing, especially with pain.
Okay. So Tracy Cowden is asking Jill if the Center for Arts and Medicine is willing or planning to share your protocol for patient preference with live music. I think that's probably, you know, a question a lot of us have is, you know, how can people in their own areas replicate some of the difficult work that, you know, both of you have been doing?
Yeah, absolutely. So we're writing up a manuscript right now for submission. I think the call we're submitting to is due in June. So we hopefully will have a publication coming out, but in the meantime, I'm very happy to share. So anyone can email me and I'm very happy to share a protocol.
So with COVID, obviously there have had to be a lot of changes made. And I wonder if there's been if you've gained any insights into how iTunes or Spotify or some of these other services, this is something that Darina Petrovsky is asking, might help connect people with music or identify musical preferences, you know, for whom it might be harder to find the music, or in the case of COVID, where you can't have a musician coming in.
So our musicians have adapted beautifully. One thing those who are involved in music in our audience will know is that among art forms, music has been one of the hardest to pivot to Zoom, because it just, collective singing and making with music doesn't translate with the, network delays and such. So there are, of course, apps, and it's happening at a professional level really beautifully. But what we've found is that via Zoom, with a one-to-one interaction, our artists, musicians in particular, have been able to engage with patients. I think Sienna talked a little bit about that. She's done beautiful work, as have all of our musicians and residents via Zoom. So they do continue to work with patients via Zoom. Our artists, by the way, never left the hospital. As soon as lockdown happened last March, the CEO of our hospital said, musicians, just like all of our hospital personnel, are essential workers, and we were expected to continue to provide our services, of course, in different and safe ways, and we had to make many adaptations. One of those adaptations was that we developed an online virtual program. So we got an icon on the patient bedside, iPads, and staff were able to basically call up artists and arts media that we required, or that we recorded and put on that app. So patients could do live, referral-based interactions with artists, or could engage in instruction that was pre-recorded, or segments that were pre-recorded. And now our musicians are in the hospital, so they often will meet a patient in the hospital, work with them when they're in the hospital, and work with them some via Zoom. Or one of the wonderful things is that now when patients are discharged, they can continue their work with artists and residents via Zoom. So we've got songwriting happening that way with patients, and beautiful work continuing.
So Claudius, I have a question for you. I think a lot of hospital settings have not decided to put the resources needed to have programs like the ones that you've spearheaded. Not thinking that they would be particularly effective. Like, how are some of what would you say to someone who wants to bring this to their own hospital, or how do they overcome the CEO of the hospital saying, look, we just don't have the money or the resources for this?
I think physicians are convinced by data, and I think same applies for administrators. Somebody said to me once, administrators can count better than they can read. So if you provide enough data and enough publications and do the hard work Jill and my team puts into to provide high quality scientific work that proves the efficacy of music in the healing context, then administrators will be convinced. And it is what drove me into that field in the first place. I found that there were a lot of providers who were passionate about music, but there was not a ton of data that would convince providers who are not like us, who innately know that music is so positive and important, and would convince them. But with any form of therapy, with any new operative procedure, I think hard data, well-conducted studies will convince both administrators and decision makers.
And to help facilitate that, that's one of the reasons the Sound Health Network was created. So I'm going to ask our project manager, Stephanie, in the chat to put a link to one page of our website where we list grant opportunities. It's a really golden age for grants in this space. And we have a number of them listed from the NIH and the NSF and the NEA. So I think we all agree that we need more research, and we need more rigorous research. And so, there are these opportunities available. And Jill, you've been incredibly successful at getting these grants, not just, of course, that's what you do, but I wonder if you have any tips for people who, are looking for some of these grant opportunities. Do you have a set of little pieces of advice that you can give them for how they can best prepare a grant application?
Well, when I do teach grant writing sometimes too, and I teach about how to love grant writing. And for artists, I discovered early on in grant writing that it's very much a creative act. It's much like choreographing a dance for the stage, in that you need to think about the experience of the audience and you need to take them on a journey. So getting yourself into a place where you can be creative and bring your passion and your deep understanding and vision to bear in a way that is human in terms of, you know, how it's received. And that's a delicate balance between clarity. Clarity is the most important thing. As a grant reviewer, I recognize how, again, human that process is when I'm reading 20, 40, sometimes 60 grant applications. If I have to work hard to understand it, that's a disadvantage because I'm just irritated, right? So, you know, getting yourself into a space where you can be creative, express it very clearly and concisely upfront what it is that you're proposing, and then flesh it out in a way that engages with a, you know, again, balance of clarity that's not overly flowery, not too many adjectives, doesn't tell the reader how to feel about your work, but demonstrates through clarity, through a very clear vision and how you'll accomplish that, what you're going to do. And I would say also, don't be afraid of writing grants. I was terrified when I started. I was very intimidated. I related it. For me, it was akin to doing taxes, you know, filling out horrible forms. So, you know, not being afraid to jump in and use whatever your art form is, you know, bring that to bear in the way that you tell your story.
Great advice. I'm sure your grant writing workshops are very well attended and useful. Sylvia Nakach says that in her experience with diverse and global populations, the mindful silence in between the music is almost as effective as the music offered. And, you know, I would have to agree that, you know, when I've performed as a musician, sometimes the best parts of the concert are in between, the silence that follows, you know, a piece. I wonder if either of you have any comments about that, about how, you know, it's also important to have breathing space after music to let the effects sort of settle in.
Yeah, both from a musician perspective. I mean, ultimately, music is the sound itself and the time between sound, which is silence or a pause, and to find the appropriate, the most creative duration of silence and pause can be as difficult as the interpretation of the piece. And when we come back to looking at music in the operating room, there may be parts of the surgery or the surgery itself where no music is the best choice. And it takes a creative mind, somebody who's in tune with the environment and the music itself to make those determinations. I think, like many things in life, music lives from its contrast to silence. And, you know, Horowitz, the pianist, he always talked about the sound. We go in an elevator, there will be music. We go in a lobby, there will be music. We go in a restaurant, there will be music. But it is not mindful music, and it is sometimes not contributing to well-being and the state of internal reflection. And I think silence, as brought up by the person who asked the question, is as important as the music.
And I would love to add as well, I so appreciate this comment. There's so much insight in this comment. And we train our musicians to always stop between pieces. I think the reasoning behind that is simply that when we are dealing with stress, when we're in a healthcare situation as a parent, patient, as a visitor, we're, I use the term thin-skinned, you know, I mean, we're more sensitive than we normally are. And even something we love like music can be agitating and irritating. So the last thing we want to do when we think about arts and health and the ethic of do no harm, we don't want to increase anxiety in that setting. And silence is absolutely essential to that. One of our studies quite a few years ago One of our unexpected but most important findings was that music can cause negative distraction in the healthcare setting, not only for patients and visitors, but for staff. So if we have music in public areas where unit areas where staff are trying to do work, we realize that sometimes that can even be a potential danger in relation to patient error, because we can distract staff from things like counting meds or thinking about what they need to do. And so when we did that study, and this was about 15 years ago, we immediately changed our protocols, which were loose. We did perform in hallways on units at that time. And now we always contain music and make sure that everyone who's exposed to it has consented and has the opportunity to come and go.
I think that's a really important point, because yeah, we do have so much music pollution these days. I mean, not during COVID as much because we don't go anywhere, but when you are in public spaces, when there's like music all the time, restaurants, etc. And in the hospital setting, there's so much unwanted noise, beeping machines and patients in agony, and people moving around or yelling. And so I feel like that the silence, just adding a layer of music on top of already a bunch of unwanted noise is not effective. And hopefully, the work that we do and that you do will help administrators see that, oh, sure, if you want to use the healing power of music, don't just pump, music through all of your speakers all the time, because that actually is going to be contrary to what you're trying to do.
Yeah, I think, just the reflection on the subject raises the awareness of our acoustic environment in the clinical setting, how inappropriately alarms are designed, how there's no alarm research, different from our work, for example, with NASA. NASA has an entire department on how to best structure alarms, yet in the medical space where there are many more people exposed to alarms, that doesn't seem to be that important. And same holds true for the floor, the ICU, or the operating room. And to just expand on the idea of silence, and to answer one of the questions that were asked as to what is best for surgeons, or can surgeons be distracted? We published a study in Annals of Surgery, which is our highest impact surgery journal, that compared four conditions in surgeons performing surgery in a virtual environment. And the conditions were silence, auditory stress, mental stress, or relaxing classical music. And what we found in the study was, and there's a separate arm that looks at novices versus expert, and an additional arm that looked at how music preference or the experience in a music plays, or the role music plays in a surgeon's life, how does the response to those four conditions determine the outcome. So what we found was that surgeons can operate as well as in silence under the condition of relaxing classical music. And we found that when we look at learning, that there was a greater degree of conditions. And we think that there's an auditory conditioning effect. If you combine a motor performance with an auditory input, and you hear the auditory input again, it may help you with learning. And with respect to auditory stress, it is interesting. There are some surgeons who are 500% worse compared to silence, versus other surgeons are as good as in silence. And we found, interestingly, there's an inverse correlation to the role music plays in that surgeon's life. So people like me, who are very in tune with music, love music, are much more affected by noise pollution and auditory stress, which we simulated by 2 different types of music in each ear, designed to be super stressful. And then finally, if you look at mental stress, nobody performs well under mental stress, and there will be no improvement under the aspect of mental stress. So if we then come back and use music as a way to reduce mental stress, it will help us with our motor performance. And There's so many aspects of surgery that are so similar to being a musician. And I often see in my trainees and my assistants and my partners who work with me, I wish some of the things we learned at the conservatory, how to relax our body, how be in tune with our body, how to be receptive to the input we get in our fingers. I wish I could make that more clear, but it has become a component of my training program. And now all trainees who work with me have a mindfulness component, and in some aspects I learned about stage fright and stage presence that I pass on with them to help them perform better in the operating room.
Oh, that's really interesting. I never think about stage fright as being an issue when you're a surgeon, but it must be. Yeah.
It is actually an underestimated and tremendous problem. And there is a lot of substance abuse among surgeons. There is a lot of unhealthy behavior. Some of the inappropriate behavior is related to the fact that surgeons are not comfortable in the operating room and are stressed out. And you know, a concert performance where we are on stage, where we are under the spotlight, it can be stressful. A lot of musicians strive from that, but for a lot of wonderful musicians, this is a very stressful experience. Yet at that moment, you want to make the most beautiful music possible, similar to the surgery. When you know you're in a critical situation, there's bleeding, there's stress, there's so many things you have to consider at the same time, but ultimately you have to focus down on, you know, stopping the bleeding, for example, and placing the stitch. So you have to zoom in and put all your mind into this one motor performance, similar to being on stage.
So Aaron Culverson, who's in ethnomusicology, and he has a question that I think is something that we are struggling here at the Sound Health Network to try to answer, which is that, you know, we have a number of disciplines that are coming together to do this work, and we all have different vocabularies, you know, different ways in which we talk about outcomes, you know, the purpose, the functions, the methodologies. Jill, since you really work in this very interdisciplinary center at Arts and Medicine, what have you learned that can help us sort of cross these boundaries across disciplines so that, you know, we can all sort of move forward?
That's a big question. And Aaron is actually my student and staff. So I'm going to invite Claudius. He hears from me all the time. So I want to invite Claudius to contribute to this question. But I will add it. A lot of our work is about field building at the intersections of arts and healthcare and arts and public health. And we do think a lot about cross-disciplinarity. And I think, you know, one of the most important barriers and opportunities is language, right? Learning how to cross those boundaries and listen and learn language, and also yield our language, you know, and learn how to communicate in ways that's inclusive across disciplines. But again, I want to yield to Dr. Conrad for this question so Aaron can hear a different voice.
Yeah, Jill put it so eloquently. I would just add an anecdote from when I was a child. Nobel Prize winners explaining how they came up with the Nobel Prize winning idea. And, you know, it's kind of tough reading, but I kind of learned a common theme that none of them actually made a completely novel discovery out of nowhere in a vacuum. Basically, most of them, or all of them, made a connection between seemingly unrelated fields. And seemingly medicine, natural sciences, and music are unrelated. But if you are able to bridge those two fields and create and I love the idea Jill said, start speaking with a common language that is inclusive to the artist and the musician, as well as accepted by the scientist. If you're able to bridge this and speak a language that appeals to both camps, you have the opportunity to make tremendous discoveries. And I love Jill passing on her experience. and her success as a scientist in grant writing workshops and other ways to the future of medicine coming along, because there's huge discoveries to be made. Usually when you think you have a cool idea for research, you will find 1,000 other people had the idea before and probably did it already in a more creative way than you're thinking about it right now. Having said that, in music and medicine, there are really big discoveries you can make if you are willing to speak the two languages Jill was talking about.
Yeah, sorry, go ahead.
I just want to build on that by saying that artists are great researchers. Artists make great researchers. The way artists question and inquire and use methodologies to answer questions, they make phenomenal researchers. So they're tremendous assets on health research teams.
Yeah, and that just speaks to the importance of including them, in all aspects of the process.
I couldn't agree more. I hired a pianist formerly when I was at MD Anderson to join my team, and her first scientific paper was a lot of work for her and also for me, because we just didn't speak the language. But at the end, the same dedication that drove her to be an amazing pianist, the same detail-orientedness that is required to make beautiful music, the same willingness to put the hours in drove her to write an amazing paper on what surgeons can learn from professional musicians to improve their performance in the operating room. That is now one of the standard work. And that was her first scientific paper ever published. So I couldn't agree more with Jill. It will enhance your creativity as the principal investigator, just having an artist on your team who thinks completely different. And we do not only music and medicine research, we do cancer outcome, we do stem cell biology, we do other kinds of things. And it's kind of fun to have pianists and artists think about those other problems as well, because there will be an input that you didn't think about because you speak your language. And I can only encourage other teams to look out for artists and the ways they can contribute to their team.
Yeah, I think, two comments I have. One is that really, we really do want to encourage professional musicians, since this is what we do here, to have the courage that they can do this kind of work. They can be, participatory in the research, and they can make a huge impact, even if they don't have the same kind of training, for exactly the reasons that you've said, Jill, is that they have, the discipline, and they have a whole bunch of the skills already baked in. And the other side of it too is that I think that sometimes when we speak too much with people who are very close to what we do, we tend to think small. We tend to sort of get, caught up in our own little mini arguments, and, and so having to explain to someone in a totally different discipline why what you're doing is important and interesting is actually a really good exercise in making sure it is important and interesting. So we just have a couple minutes left. I don't know if we're going to get to all the questions in the chat. And I did want to ask Jill to tell us a little bit about Epi Arts, which, was one of the other topics we were going to cover, which we're running short on time on. But can you tell us broadly sort of the direction that Epi Arts is going and what the goal is?
Sure. The Epi Arts Lab is a national endowment for the Arts Research Lab at the University of Florida. And it builds on the incredible work that's been done by Dr. Daisy Fancourt and her team at University College London. They spent the last 7 or so years looking at longitudinal big data sets to determine how arts and cultural participation impacts a range of health outcomes at the population level. The outcomes have been incredibly compelling. They've contributed to the implementation of social prescribing in the UK, which is a system wherein healthcare providers can prescribe social activities, arts activities, and the health system pays for those activities. So Dr. Fancourt is our partner in the Epi Arts Lab. She and I co-direct the lab, and we're extending her work to the United States using 7 published longitudinal big data sets in the US. We're doing analyses now to determine, again, at the population level, what the health-related outcomes of arts and cultural participation are here. So we're about 7 analyses in. In the lab, we're just starting our second year. Our second manuscript went into preprint today, actually. So we're really excited about the findings that are beginning to emerge. We've got early findings coming out. The first article looked at who participates in the arts in the United States, looking at patterns of arts participation across demographic groups. We have papers coming out on well-being, depression, and age. So.
Wonderful. And I think it's really important also to convince other stakeholders in the community of the importance of arts, and we need data to show that. So this is a way of like taking this model of you need to tell a hospital administrating using data that this is good for the bottom line. Here we are at the population level, sort of applying some of those same principles.
Yeah, our goal ultimately is that we make clearer to the American public that there is a relationship between the arts and health, like exercise, good nutrition, not smoking, those sorts of things that we recognize as basic to our health. Being creative is one of the assets that we have available to us to be healthy.
So as our last question, I want to sort of bridge two questions from the Q&A. And Monique Mead was asking about sounds more like using, like bowls and things that aren't traditionally considered music because they don't have a melody, but it's a pleasant sound. And Suzanne Hanser, who asks about environmental music therapy, in which the sounds of the hospital are integrated into the music that is improvised or performed. I wonder if either of you have worked with these kinds of other types of, sounds that are designed to induce a positive affect or positive outcomes.
Yeah, so as to the first question, so we are completing a study which we're now analyzing and about to submit for publication that looks at compositional elements of relaxation across musical types, genres, cross cultures, and their correlation to demographic factors. And we hope, and that is rooted in a project with NASA, where we hope to have somewhat culturally neutral music, and it goes somewhat in this direction, sound environments, for the very diverse team that will spearhead some of the upcoming Mars missions with prolonged space flight. And we hope to create culturally neutral, relaxing music for diverse teams, which may also be very helpful in a clinical setting. And then secondarily, I strongly believe that artificial acoustic environments that incorporate the alarms and the natural sounds of a hospital are so important. Also a project that we derive from projects we have been doing with NASA and with their alarm research department, where we want to create a hierarchy of alarms, where we want to make them personalized. And I think the future of medicine will incorporate that. I'm sure of that.
Well, Jill Sonke, Claudius Conrad, thank you so much for being a part of this webinar. It was such a pleasure to talk to you. For those of you in the chat asking about publications or links, please visit our website, soundhealth.ucsf.edu, which has a clearinghouse of publications related to this and other topics related to sound health. You can join us at 12 p.m. Pacific time or 3 p.m. Eastern time in 2 weeks on May 5th for an in-depth discussion of a paper during our monthly journal club. To register or learn more about the Sound Health Network and to take advantage of the various resources we offer, including a directory in which people can find each other and what they do. Please visit us at soundhealth.ucsf.edu. You can also engage with us through our social media accounts at SoundHealthNet on Twitter, Facebook, and Instagram, and watch archived video content on our YouTube channel. Thank you so much, and we will see you next month.
Thank you very much. Have a great day.
Thank you.
you.